PRA scan.
Yes, please.
Yes.
Share your screen, Dr. G A Munir.
I'm trying.
Okay.
Just share the first window of your share screen. Then you can go to the Ghulam Mustafa Shubro is here. I'm just co-host also. Shubro, can you hear me?
Yes, I can.
Okay. Just click on share screen and you can see the one just first window you just share.
Oh, it is. I'm trying, but
Facing problem?
yes, yes, sir. I'm facing some problems to share the videos.
Just cross all the window and just do it on time. Again. Hello.
Again.
Yes.
Yes, yes. Okay, thank you, sir.
Yes, we got your screen, sir. And please hide the Zoom meeting webcam icon.
Yes, 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 yes. Okay, please.
Okay. Okay, please.
Can you hear me?
Yes,
can you hear me, please?
We can hear you, and please continue.
Thank you. Assalamu alaikum and good afternoon. Welcome to our Bangladesh Kurgan Fellow Group webinar session, Lecture 8. Already we have learned about the basic Ilizarov frame and its components. Also, the shape zone of the upper limb from the previous lectures of Dr. Setu. Today, I, Dr. G A Munir, will talk about the shape zone of lower limb. What is shape zone? Shape corridors are areas through which pins and wires can be safely inserted without injuring the major neurovascular structures. This is the anatomy of the thigh. We all are concerned about the anatomy of lower limb. To know about the shape zone, we have to recapitulate it, starting from the middle of the inguinal ligament. Femoral vessels and nerves runs medial to the vastus medialis, under cover of the sartorius. This is the card section of the sartorius. This is the sartorius. And major vessels runs under cover of the sartorius. This is the vascular supply of the thigh. Look, the major vessels running in between the inguinal ligament, and they are almost medial to the femur and running down to the knee joint. Here is this is the supine position. In the supine position, a good shape surface approximation is represented by a straight line drawing from the intrasuper iliac spine to the medial margin of the medial condyle, and this is called the King's line. It represents the shape zone. You see the vascular vessel medial to the King's line. You learned about the sun or thumb demonstration from the last lecture. The sun is a unit of measure. It is based upon each individual's own body of extremities are real centimeters or centimeter. One son provides a proportional measurement of each individual's independent of age and sex. Goniometric system of 360 degree. This is goniometer. Goniometric system, in this system, the cuts are centered on the circumferential skin measured from 0 degree to 360 degree. This is 0 degree, 90, 180, 270 degree. For example, the wires are placed from 40 to 240, these wires from 100 to 320, and this is from 70 to 290. These are the cut levels of the thigh. Usually, the thigh is divided into 6 cuts, 1, 2, 3, 4, 5, 6. And we also have a rough idea about the upper third, middle third, and lower third. Look, in the upper third, the major vasculatures are on the intermedial portion, which is completely middle third, and in the lower third, it is posteriorly. In upper third, major vessels and nerves lies medially, which don't permit the wire to pass with a great angular crossing. Lateral surface is almost safe for Sanji screw. In the trochanteric region, look, this is the femur trochanter, and from here to here, this is the safe corridor, and you can place wires, but it is so cumbersome to place wire, so it is safe for the shunts. And this is also the subtrochanteric region. The angle is a little bit more than the trochanteric region, and this is the safe zone. In middle third, femoral vessels and saphenous nerve are in adductor canal, which occupies the middle 1/3 of the posteromedial side of the thigh, leaving entry aspect of the femur safe for wire passes. In junction of the upper third and middle third, and it is the junction of the lower third with the middle third. Here, this is the femur, and the safe corridor is from here, here to this side. This is the safe zone. And in the junction of middle third and lower third, there is a wide area. And you can place a wires in a vast areas. The safe areas is from here to here. In lower third, vessels and nerves crosses medial to the posterior surface of the thigh and enter in the popliteal fossa, leaves the anterolateral and medial aspect of the femur safe for the wire placement. This is corridor, and this is also safe. And this is the patellar zone, so you will not place any wire here. And in the posterior area, no wire should be placed in the lower third. Now, different levels of the thigh. Cut 1, just show the anatomy, see the anatomy. The transverse section is performed at the intertrochanteric line, just 1 cm distal from the tip. Here, about 70% bone is cancellous. Ischium is palpable posteriorly, which is the important guideline for the sciatic nerve. And in this case, transosseous fixation should be from lateral side. Shunt screws is preferred. At this level, recommended fixation is performed using 1/2 pin inserted from the anterolateral to posteromedial, and second from the posterolateral to anteromedial. The 2 pins are angulated at 30 to 40 degree. In cut section 2, this is 2T distal to the intertrochanteric line. Here, the femoral vessels are located intromedially within the triangle formed by the sartorius and adductor musculature. This is the adductor musculature and this is the sartorius. Sciatic nerve lies and medial in reference to the femur. This is the sciatic nerve. In this card, transfixation nerves are restricted to lateral half. Lateral half only. The wires can be placed from above downwards and from here to there, but it is more cumbersome for the patient to bear the wires here due to muscle attachments. So here also half pins are advised. Now cut 3, it is 40 distal to intertrochanteric line. Femoral vessels are lateral to femur under cover of the sartorius. This is the femoral vessels. Sciatic nerve lies posterior to femur under cover of the biceps. In this area, this is the sartorius, and under sartorius there is the femoral vessels. And wires here placed from 110 to 330 degree, and second wire can be placed from 10 to 150 degree. Cut 4. It is 60 distal to intertrochanteric line. Here the femur is almost cortical. Sciatic nerve lies posterior to the femur. Femoral vessels and nerves lies in the adductor canal bounded by the sartorius, vastus medialis, and adductor longus and magnus. This is the adductor canal, and you must process about this. During placing wires in this card, medial entrance should be more than 300 degree. Here is the adductor canal, so you should not place wire between 300 degree. It should be above 300 degree. And wire should be placed 310 to 90 degree and can be placed from 130 to 350 degree. You can place a wire from 40 to 2 degree, but it is difficult. It is for the highly expertized surgeon like our Bari sir. Now the cut 5, it is 80 distal to intertrochanteric line. There is an arc. You can see a line, red line here and here. You can there is an arc from 110 to 270 degree, and it is fully shaped for the wire insertion. Posterior zone from 120 to 260 degree must be avoided. Here is the neurovascular structures. Wires can be placed here at 60 to 70 degree and at 110 to 320 degree. Cut 6. It is 40 proximal to the knee joint. The popliteal artery and veins lies posterior with the sciatic nerve. That is, all the neurovascular structures lies posterior to the femur. In this card, multiple wires can be placed as desired. Introduction of the transosseous wires in lower third is relatively safe, except posteriorly. Transosseous wires can be placed 310 to 100, 80 to 280, bisecting these wires and these wires. That is 60 to 250, 100 to 300, 310, and a third wire between 80 to 280 degree. Now we are in the leg, and this is the anatomy of the leg. You see, here is the entry view of the leg, the posterior view. In entry view, the vital structure winds round divided into two: superficial and deep peroneal nerve. Superficial nerve runs here, and deep peroneal nerve runs with the entrotibial artery midway of the leg, posterolaterally to the tibialis anterior muscle. And in posterior view, this is the soleus muscle. The major vessels, that is popliteal vessels, is continued distally, and it is divided into two. The entrotibial artery runs between the tibia and fibula, and the posterolateral artery along with the tibial nerve is on the middle side. Cuts levels of the leg. The leg has also 6 cuts. In cut 1, just inferior to the knee joint, you see the anatomy. Major neurovascular structures are posterior to the tibia, and this is the common peroneal nerve, which lies just behind the neck of the fibula. Wires can safely inserted within an arc of 220 degrees. These from here to there, you can place wires. Safe zone extends from here to the let the fibula, exclude the patellar attachment. This is the ligamentum patellae. Wire placement in this part 1. If you fix the fibula, you must insert the wire through the neck of the fibula from 100 to 300 degree, 310 degree. You should not place wire from medial to lateral side in this situation. Here, the neck of the fibula is the surface landmark for the common peroneal nerve. Optimal divergence achieved by passing wires from 100 to 310 degree and 60 to 260 degree. Transfixation wire, if you want to place here, then you should place the wire aiming 30 degree anterior across the proximal tibia from lateral to medial to exit medial to patellar tendon. Now, cut 2. It is 40 distal to articular surface of the knee. In this here, vessels run posteriorly. This is the major vessels. Posteriorly, tibial nerve is separated by the popliteus muscle. Common peroneal nerve is located directly lateral to the fibula or passing posterior to anterior. Look at the common peroneal nerve. Dangerous zone at this level include the lateral fibula and of course the posterolateral portion. This is the dangerous zone. In this cut, fibular fixation is strongly contraindicated for adjacent common peroneal nerve. You should not fix the fibula. Tibial fixation done by passing wires from here to there and from 80 to 30 degree, and also you can place wires and you can place a sponge here also. Cut 3, it is 60 distal to knee joint. Major neurovascular bundles lie in the space between the tibia and fibula. All the major vessels in between the tibia and fibula in cut 3 position. Entrotibial vessels lies on the interosseous membrane, including the deep peroneal nerve. Posterolateral vessels and nerve sandwiched between the soleus and tibialis posterior muscle. as the neurovascular structures are concentrated in the central position, both bone fixation is avoided here. You should not fix the both bones here, fibula and tibia. Here, transverse wires is placed slide intro to fibula to miss the peroneal nerve. Here, we can place wires 80 to 310 degree and a second wire from 52 to 70 degree. Cut 4. This is the tibia. It is almost cortical and medially it is subcutaneous. There it here tibia is cortical near about 80% of its diameter. Neurovascular structures are in the central position. Postertibial vessels and nerve runs posterior and lateral to the tibia between soleus and posteriotibial muscles and hallucis and longus muscle. Here wire fixation is done 20 to 250 degree and 60 to 290 degree angle. Once is placed in this position here. If proximal from the ankle, posterior muscles here are increased. Than the anterior. Tibia is palpable as fibula. Sorry, fibula usually palpable due to 20 degree. Cut 6. It is 2T proximal to ankle joint. Here you see the all structures in the posterior part and some are in the anterior part. And there is no structures medially and laterally. Major tendons are palpable here. This is the tendo Achilles. Tibia is subcutaneous, anteromedially, and fibula is posterolaterally. In this cut, if desired to fix the fibula, then pass wire from 110 to 320 degree, and you can construct with 110 to 320 degree also if you want to avoid the fibula, and also by 50 to 250 and 80 to 280 degree. Now we come into the vascular supply of the knee joint. You recapitulate that the femoral artery is continuous at the back of the femur as popliteal artery, and then it is divided into two, that is posteriotibial artery and the intertibial artery. Intertibial artery is passing between the tibia and fibula over the interosseous membrane. At this level of the femoral condyle, you may place wires from medial and lateral side, both side. You should avoid the posterior side and only the inter side for the patella and the patellar ligament. And at the level of the tibial condyle, it is also there is a safe area, huge safe area on the medial and lateral side. You can place wires from 100 to 310 degree, 50 to 250 degree, and a third wire diverging the two wires. Now, it is also described in previous lectures. You will place wires, but in effect of low speed and high speed QR, it is very much important, because if you use the high speed drill, then you may pierce the vessels and nerves. But if you use the low speed drill, then when the wire make contact with the bundle sheath, then it pushes away the bundle sheath without penetration. if it is slow with RPM, slow RPM. But if it is with high speed, then it will perforate the vessels or nerves. And if it is slow, then the sheath will be displaced and it will be continued with the bone. So when you will place the wire, then you can place the wire with your hand and push it through the skin and slowly push up to the bones. When you feel the bone, then you will drive your power drill. The cure must be introduced slowly, pausing several times during the procedure to avoid burning of the tissues, particularly bone and skin. It is recommended that a low power drill with a speed not more than 100 to 1200 RPM be used. Low speed wire introduction also permits moving aside such movable soft tissue structures as blood vessels and nerves, thereby avoiding serious complications. Technique of KR introduction into the bone. Here, wire tip is moved slightly vertically to make sure it is not on the bone slope and will not slide downward or upward when drilling. Wire will be gripped by wet sponge. Then you will drill the wire through the bone side, both sides of the cortex, passing through the bone canal and bone marrow transmedullarly. If the wire is drilled incorrectly through the cortex, which can lead to development of osteomyelitis. So be sure that wire is passed between the medullary canal and both cortex. For correct positioning of a wire, before the wire tip is introduced into the skin, entrance point and exit point drilling site must be determined. You should place the wire, touch the bone, and your assistant will guide with a artery forceps or something, and you will mark that point to drill the wire to your assistant. Introduction of K-wire into the medial side of a femur. Entrance point of the wire tip must be 2 centimeters from the vessels to prevent injury of the vessels. Here, to prevent joint contracture due to wire insertion, during wire penetration of the muscles of the anterior compartment, you should place the foot in plantar flexion position, and when you will place wire from posterior to anterior, then you place the foot in dorsiflexion position in maximum. Measure of the widest part of the leg with the measuring tape. It is for the appropriate ring selection. You should select a ring which is easy for the patient and for you. For measurement, the widest part, you should measure it and then add 6 centimeter, 3 centimeter anteriorly and posteriorly to obtain the original figure. You may try the proper ring size in advance, and you also apply the Smith and Nephew special template, but it is not available. Ensure at least 2 fingers wide gap by inserting your fingers in the space between the ring and the skin. It is very much important. When you select the ring, you should see that their ring must be more than the circumferential skin size, because after operation, the swelling up of the leg, it may give hazard to the patients. Now there are some examples. These examples are from our center Kurgan, Russia. Here you see the Ilizarov rings are placed in the thigh. Here Ilizarov ring in the leg. Wires are placed from medial to lateral side. And in this picture, the Ilizarov are placed from thigh to leg. There is arcs, two arcs here, and which are held by the shanji screws. Stay home, stay safe, use safe zone, stay safe. And this is the picture, we7 making a circle that is near about the Ilizarov ring. And here the center is our mentor, our Professor Barisar, who inspired us to be an Elizavethian. Thank you, sir, for patience hearing. For live and previous session, you may visit Ilizarov Clinic, KUMC, Ortho World, and Ortho TV Live. I invite you all for the next session, Safe Zone of the Foot, Lecture 9, on 6th June 2020 at the same time, just at 4, by our Dr. MD Arifuzzaman. Thank you all. Hello. Hello. Hello, everybody. Hello. 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 Yes. Yes. Shatu bhai. Yes.
Thank you for your brilliant presentation, and you already presented it very elaborately. Now I want to give the floor to our Professor Barisar to say something. And before that, I want to give the space for our audience. If there any question to our speaker, please hands up, and any question you can do it directly to the Dr. Munir. Please. Munir, off your screen. Munir, off your screen.
Okay.
Arif, can you hear me? Dr. Arif, can you hear me?
Yes, I can hear you. Sorry, I unmute my microphone. Dr.
Okay.
Nazmullah Shetu sir, thank you for supporting me in between the blackout period. And now the most interesting session is the question answer session. And I think I said something when I was muted in mute mode. So for that reason, I want to repeat my speaking. I especially thank to Ghazi Hasan Munir, so brilliant and very time-oriented and palatable slide sharing, and especially the safe zone, the circle, all the things that you have shared are very authentic and very palatable to us. And now the special session to which we can communicate with us and different participants from home and abroad. And I divided this part into several departments. First, I will go to my Professor Mufakkar Al-Bari, and then I will go for question answer session, And at the last part of the session, I will again go back to my professor, Mufakkar al-Bari, so that he can conclude the session. And in between the speech of Mufakkar al-Bari, please, everyone, please,
Arif, please,
arrange
Arif,
your question.
may I say something?
Yes, sir, definitely,
Arif.
sir. Yes, sir, you can say something, sir.
May I say something?
Yes, sir. Yes, sir, you can say something.
Yes.
Hello,
Yes, sir, we
Can
can
you
hear
hear
you.
me?
Yes, we can hear you, sir.
Dr. Munir, it is a brilliant and excellent lecture
Thank you,
about the
sir.
safe corridor of our lower limbs.
Thank you, sir.
I appreciate you, and it will be helpful for their junior doctors and those who surgeon starting Ilizarov session. And
Thank you,
they
sir.
have to learn from your lecture more and more. Thank you, Munir, for your brilliant, excellent lecture. Thank you
Thank you,
again.
sir. Thank you, sir.
Thank you, Ghulam Farooq, sir, for your appreciation. Especially, you are very much interested for seeing the very details of the anatomy, as you told our previous session. So I think Munir, Ghazi Asrul Munir satisfied your requirement. And now I am going to my professor, Mufakkar al-Bari. Please have a comments over the full session. And after that, we will go to different participants so that we can interact in a very good manner. Mufakkar al-Bari, sir,
Okay.
can you hear me, sir?
Yes.
Sir,
Can you can
yes,
you
sir.
can hear me also, eh?
Yes, sir.
Thank you. Thank you. Good afternoon, everybody.
Thank you, sir.
Good afternoon, everybody.
Good afternoon,
Good
sir.
afternoon, sir.
My all national fellows, international Ilizarovians, Assalamu alaikum and good afternoon. Dr. Munir rightly mentioned everything regarding the inferior extremity, particularly the femur and the tibia. And every Ilizarov surgeon, they must consider it, they must know the surface anatomy. I'm talking about the femur first. Even you must think about you should mention that one regarding the pelvis also. This is also included in the inferior extremity. Or you can take another class for pelvis. Because pelvic rim, when there is a trauma, there is a great role of Ilizarov surgery in the pelvis. Okay. Regarding the femur, upper 1/3, middle 1/3, lower 1/3, he rightly mentioned everything. And for the juniors and for the newcomers, those who are willing to do the surgery in the femur and in the tibia, don't need to worry anything. Only in the femur upper third, you know the nerve or vein, nerve artery veins or vein artery nerve in the upper third. When you will see the Pupot's ligaments, that is inguinal ligament, below that you will palpate. And you must mention the Kane's line, which is started from the anterociliary spine up to the medial condyle of the femur. He rightly mentioned Kane's line. Then upper 1/3, due to anatomical constraint, we are using the shunts. And in case of femur, 5.5 or 6 or 6.5, even then you can use 4.5 shunts. It's better to use for 5.5 or 5.6 or 6.5 or 6. There are different varieties. Whichever you want, you can use that one. From different planes you can use in the trochanter region. Even you can go through the trochanter to the neck of the femur, everything. And even in femur fracture, you can use the multiple K wires, which I use all the time. In old days case, in the trochanter, in the femur fracture, femur trochanter, and the neck of the femur, you can use multiple K wires. That means 1.8 for the adults. You finish your 1/3 cross section here shown, and then go to the middle third. Most importantly, middle third is the dangerous. Perforating vessels are here, middle side, and a little bit below, if you go, there is adductor canal. You should have to keep it in your mind for that one. Even then, you can use the multiple K wires or Ilizarov wires in the middle third. And lower third is very safe. If you think about a ring is 100, 360 reflex angle. I always mention that. Whole ring is 360 degree 360 in the lower third. If you divide 270 and plus 90, 270 is the safe corridor, 90 is the dangerous corridor. 270 plus 90, it gives 360. Same in the upper tibia also. 270 is the safe, 90 is the dangerous. 270 and 90, it gives 360-degree reflex angle. Middle third is also not so dangerous. A lower third, very easy. One thing you should keep it in mind, in the lower one third of the tibia, if you take the medial border of the tibia and the fibula, draw a line, middle border of the tibia, and draw a line through the fibula. If you divide this into three portions, anterior portion medially, that one is the called neurovascular structure. You can hit the vessels, you can hit the nerves, otherwise whole thing is safe. I must pay attention to you all, and especially the Munir, I must say, he has rightly mentioned everything. And if you go through my book, small book that I is written in 2006, first book, Nazmullah Shuddu always talking about that book, he likes it. The lower, only the tibia I have mentioned, and that was written on the equinus equinocabus. I could not mention that one. And recently, I am already going to finish my superior extremity book, elaborate everything there, safe corridor, everything due to coronavirus delay. So these are the main things already mentioned. So my request to all the orthopedic surgeons, you go first with the tibia, nothing to be worried. Starting from simple fracture to any complex trauma. Start with the tibia and you will be able to do any surgery. First you capture the tibia, then start with the ankle and foot, start with the femur, then go to the upper. Then you will be able to capture everything. And one thing is this, 15th June of this month, Ilizarov birthday. Today, Valentina and Mishina, you know, they talked with me over telephone and they conveyed by their best wishes to you all. And you can join on 15th, their webinar. They are conducting this year due to coronavirus through webinar. And they will inform me everything, then I'll let you know. So you get ready for 15. And think yourself how we can next year, it will be 100 years of Ilizarov birthday. So we can deliver lecture from here. They will conduct with Ilizarov Center. And now one person is from Portugal. He's also one of the professor, I know him. He's delivering from his country and they deliver it to the Kurgan Center. Same case we'll do it. We'll let them know what we can do. Okay, we'll think ourselves. So thank you very much. Now you can continue the questions and answers. Thank you very much.
Thank you, sir, for your nice comments. And I think please, everyone, please mute your microphone so that noise is less. And especially your experience sharing. And if you give us the hope that you don't need to be worried to do Ilizarov or insertion of the wires during your Ilizarov technique, because the knowledge of the anatomy, delicate anatomy, is the best safeguard for your performance in Ilizarov surgery. And now I am going to, I will come back to you, sir, after the later part. Even you can interact whenever you want to interact in this session. I want to go different surgeons. So far, I did not see any question from our participant. So I am going to different foreign participant and our country participant so that they can share their experience of wire technique in lower limb. As lower limb is a very important and very many of the orthopedic surgeons just practicing the Ilizarov surgery in tibia and the femur. It is a very popular technique in Ilizarov surgery. So every surgeon have some special tics, have some personal observation regarding the lower limb Ilizarov wire fixation. So I am going to at first, I am going to my co-host, Dr. Nazmul Huda Shedu. Please share your tricky point for wire fixation in the lower limb. Nazmul Huda Shedu, please unmute your microphone. And,
Okay.
yes.
Yeah, thank you, Arif.
Yes, sir.
Thank you. I just share my experience and got the tips from my mentor, Professor Bari sir. I always convey the message to our followers and residents also that if you want to do a Ilizarov surgery, at first you go through the books by our sir. That is the pocket book of Ilizarov. That is very nice, very precisely demonstrate the wire insertion and where the ring position, everything. I just share some tips that was already said, told our sir. That is, femur is divided into three parts: proximal third, middle third, and distal third. Proximal third, anterior zone is dangerous. Middle third, medial zone is dangerous. Posterior third, posteriorly is dangerous. Basic things. And for the tibia, that is the medial border of the tibia. Do not avoid the passing the wire behind the medial border. And when you insertion, then again divide the longitudinally. It is about three zones: proximal third, middle third, and distal third. And again, longitudinally, it is also divided into three parts. That is distally posterior lateral, middle posterior third, and middle third, and anterior third. If you from the proximally, anterior most lateral part is dangerous. Middle third is dangerous, and distal third, anterior third is dangerous. It is a basic concept, and here distal third always should be remember that medial border of the tibia don't go beyond this the tibia, because very closely there is a posterior tibial artery. Be careful about it. Another thing, when you insert the wire, you should remember that in the femur you should avoid the middle portion of the about 3 to 4 centimeter medial portion of the thigh should be avoided, because it may disturb the knee joint movement and it may cause the stiffness of the knee joint. So you should avoid this area. Another thing, proximal tibia, if there is no fracture or any pathology, you should avoid the proximal 14 to 15 millimeter, because the capsular attachment beyond up to the 14 to 15 millimeter. So you should avoid this area. There is less chance of infection or septic knee. For this reason, we always remember this in our Ilizarov surgery. Thank you, Arif.
Thank you, Nazmul Huda sir. Please be with us. You are also co-host. And now I'm going to some of our foreign participants for sharing their experience about the lower limb Ilizarov technique. I am seeing the Roy Imaniado. If Sir Roy, can you hear me? If you can hear me, please unmute your microphone and please communicate with us. Roy Imaniado. Hello, sir. Can you hear me, sir? Okay, I think we cannot get connected with, and I think if the Golam Farooq sir is here, I want to hear some opinion from him. Otherwise, I will go to one of our foreign faculty. His name is Atkunle sir. Yesterday we have a nice talk with Atkunle sir regarding some clinical cases. Atkunle sir, please unmute your microphone and you can join with us. Atkunle sir, can you hear me, sir? Okay, I cannot connect it with Atkunle sir. Dr. Ghulam Mustafa, are you here? Please unmute your microphone. Dr. Ghulam Mustafa, co-host, please unmute your mic.
Yes. Yes.
Dr. Ghulam Mustafa, you can share your experience of lower limb Ilizarov wire technique, and if you have a tricky point or any observations, please you can share us.
First of all, thanks to Dr. Munir. He nicely elaborated everything. Thanks for his nice presentation. For the beginner, I think regarding lower limb, especially the femur is cumbersome for the beginner. And who are beginner should try especially the tibia first, so that they can easily perform the Ilizarov and get confidence. I think our Professor Mufakkar Bari sir's book will help furthermore. And that's all. Thank you.
Thank you, Ghulam Mustafa, for your nice and short comment. And I think yesterday I talked with some of the residents who are doing thesis in Ilizarov surgery in Bangladesh, in Nasser, in Nitor. I am seeing some of the surgeons here. So I'm just, though I'm not sure about that, Dr. Shironamhin Minhas, if please unmute your microphone and you can share your opinion. Dr. Minhas, can you hear me? Please unmute your microphone. Dr. Minhas? Sorry, I cannot connect it with Dr. Minhas. So,
Dr. Arif.
Sorry?
Yes, I am Dr. Ghulam Mustafa.
Ghulam Mustafa, yes, please.
Okay. I want to take some comment from Dr. Shantanudhar Imon from Sylhet.
Yes, sir, please.
Dr. Imon?
Please ask him to unmute. Dr. Imon, if you can hear us, please unmute your microphone and please open your video webcam also. We can see you.
Dr. Imon, can you?
He's already connected. Okay, then we'll go for the other discussion. And now I am sharing my experience about and my points about the lower limb Ilizarov fixation. I personally, I always try to, when the femur fixing the wire in the femur, just stay lateral to the that Keynes line, that is the line joining the anterosuperior leg spine and the lateral and the medial condyle. And you always stay, if you want to put any wire from the lateral side, just stay at the line of sartorius, stay out at the line of sartorius. So you cannot pierce or any fear of piercing any nerve vessels. Don't go straight posterior in any part of the femur. Don't go straight posterior. Then if you go straight posterior, then you can pierce the sciatic nerve. You know that sciatic nerve is a very good diameter in the upper part of the thigh. And usually sciatic nerve and radial nerve, these two nerves is so sensitive that even body is anesthetized. If you pass just a very closer to the sciatic nerve or radial nerve, there is a definite flickering movement of fingers or toes, and it will warn you about you are very close to the nerve. So if you pass your wire through the cortex, then just drill, just hammer the wires to pass the rest of the soft tissue. So this is on my tricky point, and usually the middle third adductor canal and the pulse sometimes is very palpable. So don't go to the through the adductor canal. Usually, if you want to exit any wire through the posterior medial part of the thigh, it is safe. But the one problem, if you put the wire in posterior medial part of the thigh, this area is very bulky and usually severely affected with the wire tract infection when you put the wires in more bulky part. So this thing you should keep in mind. And my part of presentation is the foot. I will go for foot on the Saturday. And now my point of the Ilizarov wire fixation for the leg. You know that the anterior artery just peeping, reach the anterior compartment on the proximal aperture of the interossseous member in the upper part of the leg, and that just visualize one idea that from that aperture anterior tibial artery just goes a little bit upward direction to the anterior tibial line at the ankle. So just think that the anterior tibial artery is gradually upriding the surface of the medial surface of the tibia and goes to the anterior part of the leg. So if you put the wires, you should just keep in mind that this anterior tibial artery traversing obliquely from the proximal part to the distal part of the leg in a oblique manner. And my professor Bari sir nicely said that for fixing the wire in the ankle, just divide the anterior shin line or a line connecting to shin and second toe and to another line is subcutaneous border of the lateral malleolus, divided into 3 parts, and you are safe in the lateral 2 part. Don't go to the medial part. So it is very safe area, and always maintain the good position of the knee during insertion of the wire for full range of movement. For ankle also is very vital. And now I am seeing some surgeon from Kumilla, Narayanganj, Dr. Abdul Malik. He's a very good friend of us, and he's a very good Ilizarov surgeon and also fellow of Professor Bari. He is connected with us. And please unmute your microphone, Dr. Abdul Malik. Can you hear me? Abdul Malik, can you hear me? Yes, you can join with us with your comment about the lower limb Ilizarov fixation. Yeah, yes, we can hear you. Please communicate.
Yes.
Communicate with the speaker and also our Professor Bari sir. You should use the my earphone to just have a good contact with the audience. Otherwise, the noise is more. I think we will come back to you in the later on. And now I am going to. Yes, sir.
I want to take some comments from my resident.
Yes, sir.
I can see there is Dr. Habib and Dr. Zakir is there.
Yes, sir.
I just want to say something about our webinar from Dr. Zakir, resident of our NITO. Please, Dr. Zakir, can you hear me?
Zakir, please unmute your microphone. And we always encourage this young chap, and they are also doing the maybe in thesis in Ilizarov surgery. Dr. Zakir, if you can hear me, please.
Dr. Zakir Hussain.
Dr. Zakir.
Can you hear me?
I already unmuted your microphone, Dr. Zakir.
Dr. Zakir, unmute your microphone. Unmute your microphone. Yes.
Hello.
Yes.
Sir. Assalamu alaikum, sir.
Alaikum.
Sir, I am Dr. Zakir. I am a Phase B resident from NITOR, and I am doing my thesis regarding Ilizarov in the femur.
What is your the title of the thesis, sir?
Munir sir, for his brilliant presentation And I am a beginner, and as I am a student of Phase B resident and in MS orthopedics, it will be very much helpful for us, and I will be in this session regularly, and hopefully will be grateful. Thank you, sir.
Dr. Zakir Hossain, what is your thesis title? Can you please mention again?
So my thesis title is treatment of infected non-union fracture shaft of the femur by Ilizarov technique.
Thank you. Nice. Dr. Zakir Hossain, I want to add one thing is that we are very fortunate that we got Barisar during our residency and our thesis time. But I think you can also communicate with Barisar now from time to time. And this platform is for Ilizarov, basic Ilizarov for the beginner. And if you go to our previous session in YouTube and other link, and you can enjoy all the details. And our presenter are doing a very good job. They are focusing on every details, especially that is very much helpful for the beginner. So stay connected.
Yes, sir.
And please communicate all the Ilizarov, new Ilizarov surgeon who are doing thesis in Ilizarov surgery. Please convey the message to them so that they can connect it with us in this Ilizarov platform. Thank you. Thank you, Zakir Hossain. And if you don't have any question, I am going back to my professor Mufakkarul Bari. So Bari sir, please have your comment on the overall.
No time, Arif, no time.
Sir, yes, it is. Time is already. We just have just passed.
Any foreigner, no foreigner from Nigeria. They're not here today.
Yes, sir. There are foreigner from IKI. There are few Nigerians here. If you want me to unmute,
they're not willing to ask any question. No.
I think they are thinking.
No comment.
There is a Nigerian friend. I asked him to unmute. Iki Oki Silly. If please unmute your microphone, and if you can hear me, please connect with us. Hello. I think he's out of range now. And sir, now I am seeing one of our resident. So far I know he also doing a thesis on Ilizarov surgery. So we can congratulate him.
Who is that? Who is that man?
So Dr. Mamunur Rahman. Mamunur Rahman, Dr. Mamunur Rahman, are you here? I just see his face now. Please unmute your microphone. Please
let them speak.
Yes.
Let them speak. Yes.
Yes,
let them speak. Rashid Hassan কিছু বলো না তো. Rashid Hassan দেখা যাচ্ছে. I'm seeing Rashid Hassan. He never speaks.
Sir, I'm just unmuting Rashid Hassan, and in the meantime, I'm searching about the Mamunur. Mamunur Rahman, can you hear me, Mamun bhai? Please unmute your microphone. Yes, Mamunur Rahman, please unmute your microphone. Yes. Please introduce yourself and tell us about your thesis and all the other things.
Mamunul Haq. I am
sorry,
Dr. Mamunul Haq.
Sorry.
And just finished the 2 years third part in NITOR and have joined in the department of NITOR. My thesis is treatment of infected fracture non-union of tibia by Ilizarov external fixator.
Welcome, Dr. Mamunul Haq, new Ilizarov, and sir, Dr. Mamunul Haq is from India, and he is also a very good friend to me. And Mamunul Haq, please, you already present full session, and you can enjoy also in YouTube. And please pass some comments, and if you have any question regarding the session to our speaker Gazi Munir.
Munir sir has explained every basic matters to us very beautifully. I have to hear it again 2 to 3 times at least. a very beautiful presentation, I have to say.
Thank you, Mamunul Haq. And
Dr.
especially,
Arif,
yes, sir.
Dr. Arif,
Yes, sir. Nazmudin, sir, please.
I want to connect with Dr. Habib. He is also our resident. He is doing a thesis on Ilizarov. Mr. Habib,
Habib.
Dr. Mohammed Habibur Rahman. Can you hear me?
Yes, sir. Sir, yes, sir. Sir, I can hear you, sir.
Okay.
Hello.
Yes, Habib.
Speak some comment. Say some comment about the webinar and your feelings.
Yes, we can see you also.
Sir, assalamu alaikum, sir.
Okay.
Walaikum assalam.
I'm Dr. Fesby resident. This is on open fracture tibia.
Yes. Your topic is open fracture tibia with Ilizarov.
Primary Ilizarov in open fracture tibia.
Is there any grade?
Open fracture means ki 1 to all gastillo full or
up to gastillo 3B.
3B. It's very
sorry,
big.
Sir. 3A, sir.
Up to 3A. That is simple. If 3B, that is quite low. 3A. Okay.
3A porjanta, sir.
It's okay.
Okay.
And sir, Shetu sir and our consultant, Dr. Shetu and Dr. Rakib Monjur helping me, sir. They are very helpful, and I'm very much grateful to them. And sir, sir, Professor Bari sir, I want to meet with you, sir. But
door is open. Door is open. No problem.
Sir, I will certainly greet you, sir.
Everybody is talking with me. I'm talking with them all the time. No problem.
Thank you, sir. I think I will get support from you, sir.
I'm very happy that 3 people from Kurgan, 3 people from Nitor is joined here, and tell the other to invite them. Learn Ilizarov, then you will not face any problem in your life, I tell you.
Thank you, sir. Thank you, Habibur Rahman. Habib, Dr. Habib and Dr. Mamunul Haq, they are new Ilizaravians and very enthusiastic and a very fresh knowledge. And we all will congratulate them and inspire them. And for Barisar, Barisar door is open for all of us. Every time.
All the time.
All the time. So don't feel free to communicate with Barisar if you have any problem regarding your theoretical knowledge, even some case series or other things. You can communicate with Professor Barisar anytime. And now I am going to Dr. Rashid Hassan Rani because Barisar want to talk with Rashid Hassan Rani. Please unmute your microphone and express his feeling. Rashid Hassan Rani, sir.
Yes, sir. Can you hear?
Yes, sir. We can hear
yes,
you.
Yes.
Assalamu alaikum, sir.
Walaikum salam.
Thank you, Dr. Arifudjaman, for allowing me to say something. First of all, I want to convey my respect and salute to our Professor Barisar for his continuous support and guidance and inspiration. Sir is a great surgeon and great man also. I always respect and pray for sir. And I also convey my thanks to all Kurgan fellows who's doing their job very nicely. And I congratulate and thanks to Dr. G A Munir for his very informative and knowledgeable presentation. And I also convey special thanks to Dr. Arifudjaman for taking present time demanding initiative at that pandemic situation. Actually, Dr. Arifudjaman is my senior colleague, and he also my brother and good friend also. I learned many things from him. Really, he is a good guy, and he always inspired me and teach me. And I personally know all the Kurgan fellows who are always think about development of Ilizarov technique in our country. They are always try to teach and share their experience and knowledge. It is very much effective. This webinar is a very effective for beginner like me. And again, I convey my thanks and respect to Professor Barisar and all Kurgan fellows. Thanks to all. Assalamu alaikum.
Thank you, Dr. Ashutosh Rani. From now, I am going sequentially from the speaker, then do two co-hosts, Dr. Nazmulhuda Shetu and Ghulam Mustafa, and after that, Dr. Mufakarul Barisar. And after all this speech, we will conclude the session. And now I am going to the speaker, G A Munir. And if you have something to say overall of this participant interaction and other things, you can say. G A Munir, sir.
Thank you. I have delivered my lectures in details. I have help from this book. This is written by our Barisar.
Oh, thank you.
And thank you, Barisar, for this. And today, from the lectures of this day, you can have the idea about the lower limb, the femur, and the tibia, the anatomy, and the wire placement. And I think you will very be easily done the Ilizarov technique in the limb, and then that's the final. And I concluded. Thank you all.
Thank you, sir. And before going to Nazmulhuda and Dr. Shetu, I just want to connect with Dr. Rajesh from India. He is very steady.
Nepal.
No, sorry, every time I did this mistake. He is from Nepal, and he is connected just from first to last in every session and enjoying all of our session. And just a few comments today's session. Dr. Rajesh from India. Yes, from Nepal. From Nepal.
Sir, thank you, sir. It was a very good presentation, and I learned a lot from you. Thank you, sir.
Thank you for your stay connecting from first to last, and please stay connected in the future session also.
Sir, yes, sir.
Yes, sir, thank you. And now I'm going to Dr. Ghulam Mustafa. Ghulam Mustafa, are you here? I think Ghulam Mustafa lost the connection. And now going to Dr. Nazmulhuda.
Dr. Arif, may
yes,
I say something? I'm Dr.
Saiful.
Saiful.
Saiful. Yes, please. Yes, sir.
Can you hear me?
Yes,
can you hear me?
We can hear you, sir. Yes, sir.
Assalamu alaikum and very good evening. At first, I especially give the thanks to our Ilizarov pioneer, Professor Barisar, who is my very much popular, respected teacher. And I also give special thanks to the organizer and the Kurgan Bangladesh Fellow Group. And I am following all the session, trying the best. This is very nice presentation by Dr. G A Munir bhai. He was also my CA during at the time of as a medical officer in NITOR. He was a CEO of Professor yes, sir. Rizvisan. Then I was the medical officer. Though I am not Ilizarov surgeon, but in periphery as a tertiary medical college, we have to do everything because in our medical college there are 3 units. In each unit, every patient is admitted regularly, and we have to do also Ilizarov. That is why this is my request. These are general Ilizarovian, not specialist, so super specialist like us about Ilizarov. And my another question to Professor Barisar, post-operative complication of Ilizarov in the tibia. How can we overcome the space, reduced space in posteriorly between the cuff and Ilizarov ring. How can we overcome in post-operatively? We always take the prevention to maintain the space anteriorly and posteriorly. But if the patient prolonged time in say lying position, then there may be a complication to reduce the space between ring and cuff muscle. How can we overcome? Thank you, sir. Thank you, everybody.
Thank you, Saiful Islam sir, for being with us. And I will go to my Professor Mufakkal Bari because he has also the slot. He can have your answer at that time. And for your information, Saiful Islam sir, we have also a session on the complications of Ilizarov technique and rehabilitations. So please stay with us and you can enjoy all the session. And now I am coming to Dr. Nazmul Huda Shetu sir. Please pass some comments because we are just coming at the end of the session. Nazmul Huda Shetu sir.
Yes. Thank you, Dr. Arif. And first, I want to give thank you to Dr. Munir. He deliberately and details presented the safe zone of lower limb. Thank you again. And thank you to our all audience to participate with us and inspired us. And at last, thanks to Dr. Arif, nicely conducted this session. And overall, our professor, our mentor, Professor Dr. Professor Mufakkal Bari, is always with us, and we always respectful to him. And my request to our audience to continue with us and keep touch with us for the next session also. And your connection with inspired us, and we will try to our best, give the best work and best presentation with you. And your criticism will encourage us and correct us for the future lecture. And your demand will also try to fulfill for the next session. Please stay with us and connect with us and criticize us. Thank you.
Thank you, Nazmul Huda Shetu sir. I am just watching that Idris Ali sir. He is very much connected from the first to last of the session. Sir, if you want to say something, you can communicate with us. Idris Ali sir, please unmute your microphone and you can communicate with us. Idris Ali sir.
Hello, can you hear me?
Yes, sir. We can hear you, sir.
Thank you very much. Assalamu alaikum, Bari sir. I am enjoying the lecture and try to, yes, sir. Thank you. Try to increase my knowledge. Though I am not practicing Ilizarov, but let us start from knowledge, gathering knowledge from you. Thank you very much.
Thank you,
I am
sir.
always with you.
Yes, thank you,
Okay,
sir.
thank you.
Please keep connected with us. And now Ghulam Mustafa is back. Ghulam Mustafa, you can say something at the conclusion. Ghulam Mustafa?
Yes, Dr. Arif.
Yes, yes.
Okay, dear all participants, thank you for connecting with us. I think it will be better for your knowledge about Ilizarov. So always be connected with us and participate in all the rest sessions so you can enrich yourself. Thank you.
Okay, now I'm going to Professor Mufakkal Bari. Before going to Mufakkal Bari, I want to share you something that if you miss the lecture, and we know everyone is busy as the COVID condition is worsening in our country, but the hospitals and our private practice is just open up in different part of the country. So you are busy in your clinical practice. So you can enjoy all the lectures as much as time you can and as many times you can in our YouTube channel, both in Ortho World, both Ilizarov Clinic KUMC and in live Ortho Live. And you can enjoy all the things. And our next lecture will be presented by me on 6th of this month, Foot Ilizarov and Essentials of the wire technique. And now I am going to Mufakkal Bari sir. And sir, you know that there is a question from Saiful Islam sir about the Ilizarov in the lower limb. He had a question, so you can answer the question and also overall comments about the session, and please conclude the session also. Mufakkar Bari sir.
Yes.
Yes, sir.
Assalamu alaikum again.
Walaikum
First of all, I must pay tributes to the mother of Saiful. I tried 3 times to talk to you. That day, I don't know whether you are busy at that time and you are sad at that time.
Sorry, sir. Thank you, sir.
3 times, and
Thank you, sir.
I've written regarding your mother's that is quite different. So yes, Rabbi Rahmuma Kamar Bayani Saghira, all the time you just without namaz, with namaz, all the time you utter in your tongue. So
yes,
that will be for you and for your parents all the time. So thank you very much that you have joined today. First time that I'm seeing that you are here. So, I am very much dedicated from the very beginning of my life. I have chosen this Ilizarov. When I took the classes in Nitor, I all the time told all the orthopedic surgeons, please, once in a life, we the Muslims, we are going to the Makkah. You, the orthopedic surgeons, one in a life, you go to the Ilizarov Center. If you don't go, don't do it, but you must know the indications so that you can transfer the patient to other orthopedic your colleague. I all the time telling. You see, in Ilizarov Center, 370 orthopedic surgeons, 300 Ilizarov surgeons, 70. And how many Ilizarov surgeons in my country? Their population is 14.5 crore, and my population is 18 crore. Think about that. Only in Ilizarov Center. What about the Moscow? What are the St. Petersburg? Other cities, they have a lot of Ilizarov surgeons. That's why I tell all the time, those who are entering into the residency, you must invite them to come to learn this Ilizarov. Not to make money. Money will be decided by your Almighty Allah, but you will get satisfaction. I tell you, no other subject in orthopedics you will get satisfaction that just like Ilizarov, because it gives you thinking, mathematical calculation, and result is so nice if you fantastically like this one. You must love this subject. Those who are yes doing replacement, good. Yes, arthroscopy, good. But think about the deformity. Lots of varieties you can change with this. Starting from trauma to deformity in the world, only the Ilizarov with the best answer. Any kind of, think about the congenital acquired deformities. Deformities with shortening, deformities with infection. And third world country, my country, all the time will get this kind of problems. And you'll face day to day in your life. If you send to orthopedic surgeon, one osteomyelitis case, one LLD, one deformity, every day if you send the patient to this orthopedic surgeon, he'll run away. What can I do? So this technique, I tell all the time that you must learn, you must know the indications. Regarding your questions, answer, it's very simple. Meticulous, intelligent follow-up. Ring size, this is your ring. Circumference must be 2 fingers all the time. All the time, 2 fingers. Use the smaller rings for stability. Use larger rings whenever necessary. You are looking at edematous leg, you must take the full ring, bigger size ring. And a small, it will give you stability. And in and 2 fingers breath all the round. And you should have to check yourself every day. If you do it, you have done the case today, next day you must check. Next day you must check. Every day check. If you don't check, you'll face problem. Yes, surgery, after the surgery, Ilizarov technique starts treatment. And in other cases, plate, screw, nailing, one time you have done, finish. Now this is day by day. You should have to control yourself and meticulous, intelligent follow-up. That's why I tell all the time, Ilizarov, I, intelligent, meticulous follow-up. L, lengthening, you can do. Again, I, you can control infection. Z, zigzag, deformity, angiogenesis, adaptable, reliable. Lots of opportunities you can do. O, V, Victi, versatile. This is Ilizarov. So you got your answer, Saiful?
Thank you, sir.
And
Yes.
finally, I must congratulate all my, because I love all this group. Those who are attached with this. They're all my very much favorite, you know. Today or tomorrow, everybody will be translated to the next one. I am the first man because I am now elder than you. And who will go fast? No. But obviously, I will go fast. This is the theory. Okay? Nobody can say. So, what my aim and my motto, so that you learn something, you tell you serve the people, so that after my death, you can remember that Dr. Bari was like this. I always, you know, this is called in Russia, Sudba. Sudba means your fate, and how much money you will get, that already decided by Allah. But you should have to, at the same time, Inna alladhina amanu wa amilu salihat. You believe in Allah, you are doing righteousness, nothing to be worried. Allah is told in the Quran. So my motto, those who are related with this, I know them very well. They're all my lovely guys. From the core of my heart, I always, I want that they learn it, captured it. And in Bangladesh, Ilizarov, no other subject I can tell. And everybody loves. The Bangladesh is doing, particularly Ilizarov technique, very good. Russia knows, China knows, India knows, Korea knows, because we are holding. Why? Because of dedication, devotion, honesty, and target. If you embark everything, you'll be able to learn a lot of things. And why I lie like this, Ilizarov? I'm doing it, unlocking, plating, everything. When problem arises, then you can solve. You can solve with this single technique. Only you should love yourself. Now the test they understand. Arif, they know test. Ronnie, Rashad, G A Munir, see. Shetu, see. Everybody know what is the test about it. And they're earning a lot of money at them. Because they're loving this technique. And it will give you, Saiful, so far I know you also do. Try to do it. Other thing is okay. Then you can solve a lot of problems in pediatric, in geriatric, in trauma, in deformity correction, everything. So this is my, always I tell to my junior colleagues, they are my colleagues, they are my students, now they're colleagues. And today from Kurgan Center phoned me on 15th, they are going to do, and they told me, ask your all students to join in the webinar. And we'll join on 15th. Because I had to go there this year, but due to Corona, everything is collapsed. So join, tell your other friends, even if you go to the rotten place, you'll learn something. If this is the rotten place, you'll learn something. Every day we are enjoying talking ourselves. Not that we are, invite everybody. You come and learn something. And we are learning. And I am learning all the time. What is telling, I learn from my mistakes, I learn from the juniors. And this is the motto. And if you think that proud, I know everything, no. Learning, this is a continuous process. Particularly this one, Ilizarov, is a continuous process. Mathematical calculation, all the time. So thank you very much. Join again, invite other people to join with us. And you try to give us also something. The sir, you do it like this, you do it like this. And we'll gladly accept that one. And Arif, Shetu, Ronnie, Mustafa, G A Munir, Hamid in Nitor, they're everything. Why? They're doing so good jobs to lift up this Ilizarov technique. This is the technique for, I want so that 64 districts of the country must have Ilizarov surgeon 1. This is now you see what about the medical problems in my country? No ventilator. Same in no Ilizarov surgeon. Problem facing. You must set up, create how many Ilizarov surgeons we must need in every sector. And I said, they'll do it. We will talk about all this Ilizarov. And you talk about arthroplasty, you talk about pediatric, you talk about, yes, everybody should decide how much, how many, and what to do, how we can do. We must plan for that. Yes, young guys, they will proceed for that. And my dua is always, Ameen, Shab Shama dua for that. For that. You believe in me. I'm very much happy that my students, they are doing and helping all the time. No problem. You join on day after tomorrow, we will talk. After that, we'll talk by who? Hamid. Next, Abdullah. After that, I'll talk again on deformity. Let us see. Okay, Saiful, thank you very much. Thank you,
Okay,
Arif.
sir.
Thank you, everybody.
Thank you, sir. We are very much happy to get you.
Yeah, thank you, sir.
Thank you very much.
Because you makes us emotional. Sir, every time you are very inspiring to us. And I myself, I think that you are the father of Ilizarov surgery in Bangladesh. And everyone have this gratitude to you and respect to you. And
Thank you very much.
one thing I want to say that in Ilizarov surgery, we put tension on wires in patient Ilizarov frame, but it decrease tension of our mind, decrease tension in our mind. You need not to worry about the outcome or bad outcome when you do Ilizarov surgery. Ilizarov makes you free and very tension free.
Tension free, always.
I want to invite you that our Professor Mufakal Bari sir has a very nice presentation on deformity correction, deformity, basic of deformity on 9th of this month. And you also happy to know that Bari sir also have a presentation how the life of orthopedic surgeon. That will be the last presentation of this Kurgan Fellow Group presentation. It may be on 23rd or 22nd of this month. And on Saturday, I have a presentation on food. I'm trying to make it very palatable to you, and I hope every one of you please stay connected and come back to this platform on Saturday, same time, same password, same ID. I will also send you the invite also. Till then, Khoda Hafiz, Assalamu alaikum.
Thank you. Okay.
Thank you.